Okie dokie. So, neuroregulation of blood pressure. So, let's just pick this up with baroreceptors. Remember where we said these are? We've got the carotid sinus reflex and the aortic reflex. Um, Remember that baroreceptors are stretch receptors. So we're going to talk a little bit about the information on the left-hand side of your slide, and then we're going to go back and run through the loop together. So carotid sinus reflex, we're going to have some swellings in the internal carotid arterial wall. We're going to see the glossopharyngeal nerve to the cardiovascular center in the medulla. What this carotid sinus reflex is responsible for is maintaining normal blood pressure to the brain. Aortic reflex are going to be those receptors, those baroreceptors in the wall of the ascending aorta. We're going to see vagal nerve to the cardiovascular center, and our goal here is to maintain general systemic blood pressure at the correct level. So if feedback gets decreased, the cardiovascular center reduces parasympathetic, it increases sympathetic stimulation to the heart, and we move from there. So here's what we've got. On the right, look at your loop. You've got some sort of stimulus that's going to decrease blood pressure. So we have a form of hypotension. What we're going to see is we're going to see those baroreceptors in the aortic arch and the carotid sinus, they're stretching less. Remember, baroreceptors are stretch receptors. So if I decrease the pressure in those vessels, the vessels aren't stretched as much, therefore I've decreased stretch, and what's going to happen is those baroreceptors are going to send less nerve impulses. Remember, if they're stretched, they're firing at a consistent rate. I have less stretch, there's less stimulation, and what actually ends up happening is we have fewer nerve impulses reaching the control center in the brain. That control center is the cardiovascular center at the medulla oblongata. There's also a center in the adrenal medulla. That becomes important when we look at our output. So from the aspect of output, we have increased sympathetic and decreased parasympathetic stimulation coming off of the medulla oblongata. What we also have is we see an increase in the secretion of the catecholamines, the epinephrine and the norepinephrine from the adrenal medulla. Those two outputs, the one from the medulla oblongata and the one from the adrenal medulla, are going to act on two separate effectors. The first on the left is we're going to see an increase in stroke volume and heart rate. Remember, we said that cardiac output was a stroke volume multiplied by heart rate. So if I increase the stroke volume and I increase the heart rate, I'm going to increase the cardiac output. More heart leaving the blood means an increased blood pressure. Our second effector, the one that's directly influenced by the catecholamines, happens at the vessel level. What we're going to see is we're going to see a vasoconstriction, or constriction of the lumen of those blood vessels. If I decrease the amount of space that the blood has to move through, I'm going to increase the resistance. By increasing the resistance, as we've spoken about repeatedly, I'm going to increase the blood pressure. This loop is going to continue. I'm going to continue to see a decreased nerve impulse off the baroreceptors into the medulla oblongata and the adrenal medulla. I'm going to see those outputs continue and the effector results continue. And I'm going to have that continue repeatedly. We're going to keep looping through this cycle until we get to homeostasis. And in this instance, homeostasis is going to be when we've increased that cardiac output and we've increased that vascular resistance enough to bring blood pressure back to normal. When blood pressure comes back to normal, we're going to have normal stretch on those baroreceptors. They're going to reestablish or increase up to that normal rate of nerve impulse into the cardiovascular center, and we're to the medulla, and we're not going to see the outputs that we had previously. So you do need to understand this loop. We've talked about loops extensively, but you do need to know this loop. And we need to talk about syncope a little bit. So syncope is the technical word for fainting, or a sudden temporary loss of consciousness not due to trauma, and that's the key to syncope. Syncope cannot be due to trauma. Syncope can happen due to cerebral ischemia, and cerebral ischemia is easily defined. It's just a lack of blood flow to the brain. So I don't have enough blood flow to the brain, therefore I have fainting. or temporary loss of consciousness. We can have 4 different causes of syncope. The first one is vasodepressor syncope. It's a sudden emotional stress. They used to talk about women getting the vapors and getting all faint due to emotional stress, and it still happens to this day. And that's not a gender thing in any way, shape, or form. It's just a sudden emotional stress, and individuals can pass out. We have situational syncope. Fainting or syncope can result from the pressure of stress of coughing, defecation, urination, any of the above. There are drug-induced syncopes, antihypertensives that will lower the blood pressure too far, so we're not getting enough blood flow to the brain. Diuretics, where we're producing a lot of urine, right? So we're trying to lower blood pressure by decreasing the blood volume, but we drop it too far, and the diuretic causes a hypotension, a low blood volume. Vasodilators or tranquilizers are common sources of drug-induced syncope. And then the 4th category of causes of syncope is orthostatic hypotension. And that's just a drop in blood pressure upon standing. You stand up too fast, you get dizzy, and or you faint. This is where we're going to stop this particular video. When we pick back up, we will look at cardiac innervation. So what vessels are sympathetic and parasympathetically, what's moving, what's connecting to the heart directly, and what's the effect.